of the quiz number 1. So this is pretty informal. So this is just kind of the study sessions. Again, the last cohort really liked it. So I'm more than happy to continue doing study sessions because I think it is helpful, because especially for 261, the critical care class, there's so much information, a lot of reading as well. And so it's nice to kind of focus on really what you need to know to care for a critical care patient. So just to go through some of the housekeeping stuff for the test. So quiz number 1, it is worth 50 points. There's 25 questions in total. There are 6 select all that apply questions. I know everyone loves select all that apply questions. So for the select all that apply, if you do not choose all of the correct responses, you do not get partial points for that question. Okay, you score a 0 on that question. So typically what I do is I hide the exam results because I find that students get a little panicky because their scores may change going up or down based on how I grade the quiz. So the quiz grades will not be released until Wednesday. Okay, so typically Wednesday morning, I'll review the quiz. And what I'm looking for is I make sure all the select that apply are graded correctly. And then also I do a quiz analysis because sometimes some of the questions don't score well when I analyze the quiz itself. And so sometimes there's questions that I remove and I give points back. So that's why I don't the results for the grades until the next day. Okay, so hopefully that makes sense. Usually I get it done by lunchtime, so it's usually pretty quick. I just want to make sure that I'm being fair to all the students and that you get the maximum points that you can get. So, okay, so that's kind of the process I do for those. And then there is one fill in the blank question on this test. Okay. All right, so that's kind of the outline of the test. I did post the quiz study guide, and that's kind of what we're going to go over today. If you have questions, please just turn your mic on. This is very informal. It's not like another class or anything like that. It's just a place where we can chat and kind of go through some of the material that is kind of what you need to know. Okay. All right. So the first one I put on there, I kind of did it by categories. And the first one is looking at differentiating breath sounds. So we watched that video where you could hear the breath sounds. So again, that's on that video links and it's on the class outline. So you can always play that again. If you can't find the link, just shoot me an email and I'll send it to you. But it's really nice because especially being away from the bedside for so long, like I haven't been in clinical since February. So it's nice of a reminder to kind of listen to those and become more familiar with the sounds. But this is sure, go ahead, Whitney.
For the breath sounds, is there going to be an audio that we listen to and that we need to differentiate, or is it just going to be like just text questions?
It's text questions, yeah. Yeah. So it's going to be a text question, and it's going to be very similar to the kind of descriptions that I have on the guide right here. So the first one is looking at wheezes. So wheezes have a musical quality to them. They occur during both inhalation and exhalation, but they're typically louder when the patient exhales. Okay, so if you think about disease processes that have wheezes, those would be your restrictive airway diseases. So something like asthma, maybe COPD or emphysema. Okay, because it's in the airways themselves. So the diameter of the airway becomes narrower, and it creates that whistling musical sound. Okay, so if a patient had wheezes, what would you expect their CO2 to be on their gas, on their ABG?
Is it going to be higher?
Yeah, it's going to be higher, right? Because with wheezes, you have a restrictive airway and those bronchioles become constricted and the CO2 can't escape. And so your CO2 will start to build up and go higher. Okay, so that's why that occurs. So sometimes it's easier to kind of start putting some of the mechanisms of breathing together and understand why you see higher CO2s on patients with asthma. It's because those bronchioles become constricted and the gas can't escape. Okay, so let's just kind of put some mechanism behind it. The next one is stridor. So stridor is a little bit different. It also has a musical quality to it, but it's very high pitched and it's typically right over the midpoint of the throat. So if you think about stridor, it's very high pitched and it typically is an obstruction. So maybe the patient had face or neck surgery. Maybe they took an ACE inhibitor for the first time and developed laryngeal edema. Maybe it's a child that swallowed something and it's stuck in their throat. So basically it's the very top part of the trachea is blocked by something. In the hospital environment, typically it's swelling. And so the trachea becomes very, very narrow. And when air passes through that narrow trachea, it starts to whistle in a very high pitched sound. Okay. And it's almost like an E, like this. And you can kind of hear it when you listen to them. Okay. So pardon my voices, but that's kind of what it sounds like. Okay. So it's very, very high pitched and it has like an E sound to it. Okay. And again, it's either airway swelling. So it could be maybe a trauma patient that had a carotid endarterectomy and they have a lot of neck swelling. Maybe a cancer patient that has throat cancer and they had surgery in their throat and their neck. So anything that is swelling. Okay. So stridor is considered a medical emergency because it means that your airway is starting to close up and block off. Okay, so when you have stridor, you want some medications that we give. You can give racemic epinephrine. It's an inhaler that you can give. So epinephrine will help to dilate the restriction and kind of open that up. So you want some kind of a bronchodilator. Same thing for wheezes. You want a bronchodilator, but stridor in particular, racemic epi is kind of the go-to medication that they use for that. Okay. Nursing interventions, you would want to make sure that their head of the bed is upright and that their head is in a neck or in a neutral position. So if you remember that video from that gentleman that was having respiratory distress, he was kind of slumped down like this. So how do you think his airway is going to be? You want to sit their head up. You can position them with pillows. Make sure the head of the bed is at a high Fowler's position. Okay. All right. So any questions on wheezes or stridor? All right.
Actually, I do have a question.
Yeah.
You just used a couple keywords, so I just want to make sure that I'm getting those. So for wheezing,
Sure.
you referred to narrowing, and stridor, you're referring to swelling.
Correct.
Thank you.
Yep. All right, so we'll move on to rhonchi. So rhonchi are more of a rumbling or gurgling core sounds, and they're heard over the bronchial area. Okay, you hear them both during inspiration and expiration, and they will clear with coughing. So if you think about rhonchi is typically mucus production that's in the bronchial trees that you can hear rumbling around. So a lot of times you hear it with patients with pneumonia. And so typically if you have them take a cough or if you suction the patient, the rhonchi sounds will diminish or go away. Okay, so that is rhonchi. So it's rumbling, gurgling, coarse sounds over the bronchial area. Typically it will clear with coughing, often seen with pneumonia. Okay. All right. And then crackles. Crackles is a little bit different. So if you think about what crackles are, crackles is fluid. So crackles you hear with pulmonary edema. So it's fluid building up in the alveoli, and that's what you hear. So typically you're going to start to hear crackles in the bases. It can be fine or coarse, and it's kind of like if you take your hair and scrunch it in your ear like this. That's kind of what crackles sound like. Okay, so you can try that and see what it sounds like. So it is fluid buildup, whereas rhonchi is mucus. So it's a different mechanism that's causing that sound. But with crackles, if it starts in the bases and it starts to move up the lung fields, it means your pulmonary edema is getting worse. Okay, so if you're hearing it in the bases and then maybe a couple hours later it's a little higher up, maybe mid lobes, your patient is getting worse. Okay, and that fluid is increasing. So that is crackles. So they can be coarse or fine. They have more of a higher pitch sound to it, like rubbing cellophane or saran wrap in your ear or hair in your ear. And they do not clear by coughing, okay, because it's fluid in the alveoli. Where rhonchi is mucus, I can clear mucus. I can't clear fluid out of my alveoli. Okay, so even after they cough, you're still going to hear the crackles in the lower lobes. Sometimes you will hear coarse crackles in a single lobe, and that would have to do with a severe pneumonia in one particular area in the lung that has gotten down into the alveoli. Okay, so but typically they're in the bases, but you can hear them scattered sometimes if they have a bad pneumonia. All right, any questions on rhonchi and crackles?
So the main difference would just be the mucus and the fluid, right? The mucus and the rhonchi, and then the fluid and the high-pitched sound.
So yeah, so that is the difference between the mechanism behind rhonchi and crackles, how they're different. Rhonchi you're going to hear over the bronchus. Crackles you're going to hear in the bases. Okay, crackles are a little bit higher pitched. Rhonchi are lower pitched, coarse, and have kind of a grumbling. So if you ever listen to someone, have you ever had a patient and they sound like a washing machine? Just kind of that, they have a lot of extra sounds in those. That is rhonchi. Whereas crackles is more just this fine, crackly noise. I'm trying to, so if you take your hair and kind of rub it in your ear, that's kind of what it would go like. So you don't need to know the diagnosis for the test, but you do need to know it for when you're caring for patients, because you would need to know what to expect. Okay, so if I go into a room and I know my patient has pneumonia, I would expect them to have rhonchi. Okay, and if it's getting worse or not. And that's how I can tell if I'm doing a good job with my interventions. So yes, rhonchi is associated with pneumonia. Okay. All right. Good questions. Any other questions differentiating rhonchi and crackles? So again, crackles is often with pulmonary edema. Rhonchi is more often with pneumonia. So if you're thinking about interventions, if my patient had rhonchi, I'd want to make sure they were on antibiotics, they were getting suction frequently, they were doing their deep breathing and coughing, doing their symptospirometry. But if they had crackles, I need to make sure that they're on some kind of a diuretic, that I'm watching their eyes and O's. Okay, watching their intake, making sure that we're documenting their weight. Okay, so that's kind of where the differentiation comes in, not so much that you need to know the diagnosis, but the mechanics behind it direct your care. Does that make sense?
Yeah, because with rhonchi, you have the mucus and you can help clear it up with the antibiotics and everything, but because it's
Right.
fluid, you have those diuretics. You need all that to get out of them because they can't get it out themselves.
Yeah, absolutely. Absolutely.
It makes more sense now.
Yeah. Okay, perfect. All right. Any other questions? Oh, there's one more breath sound, pleural friction rubs. So pleural friction rubs, they happen during inhalation and exhalation. However, if your patient holds their breath, you won't be able to hear it anymore. Okay, so it's a creaking or grating, and you can hear it when they take their breath in and out. And typically you'll see it with trauma patients, maybe that have broken ribs, patients that have had thoracic surgeries. Some mechanical problem is going on between the pleura and the chest wall, and it's causing the lungs. So there's not enough pleural fluid between. So I've got my chest wall here, I've got my pleural cavity with pleural fluid in it, and then I've got my lungs sitting right here. And when it breathes in and out, it goes like this. But there's that fluid stopping it from rubbing against the chest wall. Well, if I don't have a fluid there, or if I have broken ribs or some kind of dysfunction with the chest wall, it can rub, and you hear kind of a grating noise. Okay, so that's a pleural friction rub. So again, it's that pleural cavity rubbing up against the chest wall. Okay, so that's kind of the mechanics behind that. So if you think about disease processes that you would expect to hear that in, again, would be maybe trauma patients, thoracic surgery patients, maybe cardiac surgery patients if they went through the chest, those kinds of things. You would be listening for a friction rub. Okay. But probably the ones that you're going to hear the most with our medical surgical type of patients is wheezes, stridor, rhonchi, and crackles. Those are your ones that you really should be paying attention to and listening for in your patients. Okay. All right. Any other questions on breath sounds before we move on?
Yes, I do have another question. So for the pleural friction rub, you had kind of given an example of which medication you would use for the other ones. Is there a specific one for that one?
Not really, because it's more of a problem with the pleural cavity itself. So it would depend what the reason was. So if it's a lack of pleural fluid, maybe they have a chest tube in, maybe they have cancer or something like that, and they have an infection in the pleural fluid, things like that. So it just depends on the underlying reason.
Okay, that's what I thought. I just wanted to make sure. Thank you.
Yeah, sure thing. All right. So we'll move on. The next one I just put on here was a definition of compliance. So compliance becomes a really important concept when you're thinking about more of those advanced respiratory diseases. So if you think about a patient with end-stage COPD or end-stage emphysema, they start to develop pulmonary fibrosis and they have very poor compliance. So their lungs become very stiff and they can't expand. So they can't take a deep breath in and stretch. Okay, so compliance is the ability to stretch and expand to be able to take a breath in. If you have a patient with ARDS, the acute respiratory distress syndrome, again, if you remember the pathophysiology of that, in that third phase, in that recovery phase, they actually start to develop scar tissue, and they remodel their lungs, and they develop pulmonary fibrosis. So again, a patient with ARDS, they have poor compliance. It becomes a problem when you have a patient on a ventilator, because if your lungs don't have the ability to expand and stretch, if I put a lot of volume in that lung and it can't expand and stretch, it's going to burst and you'll end up with a pneumothorax. Same thing if I put a lot of pressure on that lung and it can't expand and stretch, it's going to burst. So that's where you get your volume trauma from a larger breath, or your barotrauma from pressure. Okay, and it's because you have a problem.
Sorry.
No,
is that just because like over time, like it like the scar tissue, is it just because like the alveoli is working so hard, and like is that how it just develops? Like how does it develop scar tissue?
Because it releases all that clotting cascade. And so whenever you have an infection process going on, you have an inflammatory response, right? And so if you think about that inflammatory response, it sends all those inflammatory mediators, and they start to make fibrin and fibrinogen, and that turns into scar tissue. So anytime you have an injury, even if you have like an MI, maybe you have a heart attack, you cut your knee, anything that happens in the body that's an insult to the body, you automatically send out those inflammatory mediators. And part of their job is to create those fibrin fibers, the fibrinogen fibers. And what that does is it helps protect that area. But unfortunately, the end outcome is it becomes scar tissue. And so in ARDS, you get scar tissue in the alveoli. In an MI, a heart attack, you get scar tissue in the heart. So in a couple of weeks, we'll talk about that in the heart. But it doesn't matter where it occurs, you're just going to get that scar tissue because of that inflammatory response. So a lot of kind of stuff that we talk about, I find it really helpful to kind of bring the mechanism of action into it, because then it makes a little bit more sense on why that happens. So that's why those patients with COPD, emphysema, they end up with fibrotic lungs, is because they have this chronic inflammation that has gone on for years and years and years. And so it's this cascade of events that just continues to occur, and their lungs get stiffer and stiffer and stiffer and stiffer. And then they end up with that barrel chest because they've remodeled the shape of their lungs because of the scar tissue. Does that make sense? Yeah. Yeah. So compliance is really important, especially next week when we start talking about ventilators, because if a patient has poor compliance, I can't give them a big breath. I can't give them a big pressure, because it'll cause trauma to their lungs. So it becomes a really important piece of mechanical ventilation, which is why that was one of the definitions that you do need to know. So compliance is the ability of the lungs to expand and stretch and be elastic. Okay, so again, if you think about your lungs being a balloon, are they a nice fresh balloon that you can blow up and blow down, blow up and blow down, or are they old and crumbly, and if I put a big breath of air in it, it's just going to fall apart? Okay, so that's kind of compliance. All right, so the next parts, what I did was I kind of broke it up and I put some pictures and stuff in here, looking at acute respiratory failure and then kind of separating it out into oxygenation problems and ventilation problems. And hopefully it'll make a little bit more sense on why you're doing what you're doing in those patients. So acute respiratory failure, we talked about the early signs of acute respiratory failure being tachypnea, tachycardia, and mild hypertension. So if you remember that gentleman from the video, they kept kind of going to the monitor a couple of times. I don't know if you saw, but he was tachycardic in the 120s. He was actually very hypertensive in the 200s for systolic blood pressure, and his O2 sats were 75%. And his respiratory rate was like 35, okay? So he was tachypnic, he was tachycardic, he was hypertensive, and he was also hypoxic as well, okay? But the big three to remember: the tachycardia, the tachypnea, and the mild hypertension, okay? So those are your early signs that you're going to see that a patient's having difficulty with breathing. And so then you kind of have to see, is there difficulty with ventilation or is there difficulty with oxygenation? Because these are your two types of respiratory failure. So the first one is hypoxic respiratory failure, and your second one is hypercapnic respiratory failure. Okay, so we'll look at the hypoxic one first. So hypoxic respiratory failure is low O2 sats, low PaO2. So something has happened either in the alveoli are collapsed because they have pneumonia, or the alveoli are open, but the blood coming to the alveoli can't get to the alveoli because there's a blood clot there, like a PE. Okay, and so you can't make that gas exchange across the membrane, the capillary membrane. So those are some common things that you'll see with a hypoxic respiratory failure. Okay, so in here I put, so hypoxic is oxygenation, low PaO2. So again, common causes that you're going to see is pulmonary edema, because your alveoli are full of fluid, and so that gas exchange can't occur. Pneumonia, they're full of infection, and so the gas exchange can occur. And same thing with ARDS, with acute respiratory distress syndrome. You have capillary leakage, right? You have a change in the capillary permeability of your membrane, and fluid starts to leak. And so again, that gas exchange can't occur through the fluid. And so if the gas exchange can't occur, the oxygen goes back up to the heart, and then it kind of goes through the whole system again. Okay. And so with hypoxic respiratory failure, there's either a problem with the oxygen delivery getting out of the blood. So it's either a clot, maybe a low blood pressure. There's some kind of a blood flow problem getting the oxygen to the alveoli itself, or there's a problem with the alveoli being collapsed because of pneumonia, ARDS, pulmonary edema, something like that. Okay. So do you guys kind of understand the concept of hypoxic respiratory failure? Kind of. Okay. So let's kind of look at some of the mechanisms behind it. So I'm going to kind of turn the page, and then we'll come back to the ventilatory one. Okay. All right. So when you're looking at oxygenation, when you're looking at your ABG, oxygenation has two parameters on your ABG. It has your PaO2, which is your partial arterial pressure of oxygen, okay? And then it has your SaO2, which is your O2 sat. Those two, your PaO2 and your O2 sat, tell you how your patient is oxygenating. Your PaO2, a normal level is 80. Your O2 sat, your normal level is 90. Okay, so those are two numbers that you would need to know. Okay, so
is the main difference between those, like, this might sound stupid, but is PaO2 like the oxygen in your blood, and then the SaO2 is like what you're breathing?
No, you're kind of on the track. So your PaO2 is the actual oxygen in your blood system. Your O2 sat, right? We read it through the finger. It's a refractory, and it measures the amount of oxygen coming back to the heart, because you're measuring it through an external thing. So it's actually an infrared that goes through your nail bed. So it's not as accurate. So when you're looking at your patient, sometimes it's really hard to get an O2 sat if they're tremulous, they're cold, those kinds of things, because it picks it up through a fiber optic light through that O2 sat sensor, whereas the PaO2 is the actual blood in your body. Does that make a little bit more sense? There is a relationship between PaO2 and O2 sats. If my O2 sat is 93%, my PaO2 is going to be 80. Okay. And it's called the oxyhemoglobin dissociation curve. It's a big fancy name. Don't let it throw you. But basically, there's a bell curve. So as my PaO2 goes up, my O2 sat will go up. But if I have an O2 sat of 100%, I don't know what my PaO2 is. Because once you get to 100% sats, my PaO2 could be 90, it could be 400. I have no idea. So that's why we usually like to keep O2 sats about 93% or higher. Okay, and we'll probably talk a little bit more about that next week. But for this quiz and for right now, your PaO2 is normal of 80. And your O2 sat is a normal of 90, okay? And they reflect oxygenation, okay? Other things you can look at, signs and symptoms of hypoxia. So irritability, anxiety, confusion, again, tachycardia and tachypnea. Those are all signs of being hypoxic, okay? So you should know your signs of hypoxia. And then kind of how you're going to treat an oxygenation problem. So if I have an oxygenation problem and I know it's because my patient has a PE, I want to open up blood flow. If I have an oxygenation problem and I know my patient's hypotensive, I want to increase their blood pressure. if I have an oxygenation problem and I know my patient has pneumonia, I want them to deep breathe and cough, do incentive spirometry. So again, you need to kind of know what's going on with your patient so you know what interventions to provide. Okay, so we're going to look at our pneumonia guy. He comes up. So this is our pneumonia man right here. All right, so oxygenation. So pneumonia is an oxygenation problem. So if you think about pneumonia, is pneumonia and in the airway system, or is it in the alveoli? Let's see if we can't break it down to make it a little bit better. Right, alveoli, okay? So any disease process that affects the alveoli is an oxygenation problem because that's where your oxygenation exchange occurs, is at the alveoli level, okay? So, correct, right. So in pneumonia, my alveoli start to become collapsed because they're full of all this green stuff, right? They're full of sputum, they're full of fluid and infection, okay? And so if my alveoli are full of fluid and infection, gas exchange cannot occur through that fluid. Does that make sense? Yeah, okay. So anything that affects the alveoli, any disease process that affects the alveoli is going to be an oxygenation respiratory failure. Okay. So so pneumonia. So again, if you kind of read over here, I've got my papers in my hand because this is kind of small, but it's an obstruction of gas exchange. Okay, so you have decreased gas exchange so that oxygenation can't occur because you have all this exudate, you have all this green stuff. Okay, all this infection that's blocking the alveoli or collapsing the alveoli, and then the gas exchange can't occur. Okay. So signs and symptoms of pneumonia, you've probably seen or had patients with pneumonia. They have a cough. It's usually a productive cough. So they have discolored sputum, either like a funky yellow or a greeny color. They get chills. They get tachycardic, tachypnic, dyspneic, right? They get short of breath. They sometimes have pleuritic chest pain when they breathe in and out because of all the coughing that they're doing. They're really tired and fatigued, and they have decreased breath sounds because, again, the alveoli are full of fluid, and so you don't hear that air entry exchange. Okay, so they have decreased breath sounds. On this one, it just kind of has the different types of pneumonia that you can see. And then over here, it kind of talks a little bit about orders to expect. So again, you would expect a chest x-ray, sputum cultures, antibiotics, ABGs, those kinds of things. So if I had a patient with pneumonia, on what type of ABG parameter would I be paying particular attention to? Take a stab at it.
It's the PA, the CO2 and the O2, and then like your pH and bicarb, like.
Okay, so for ABGs, for an oxygenation problem, I'm looking at my PaO2 and my O2 sat only. If it's strictly an oxygenation problem. So CO2 and pH tell me ventilation. Okay, PaO2 and O2 sats tell me oxygenation. And then bicarb just tells me if my kidneys are functioning. That's all bicarb tells me, is has my kidneys activated the buffer system. Okay, so typically if you have a patient that is acutely ill, it's going to take 24 to 48 hours for the kidneys to be able to activate that buffer system. So it takes a lot longer. So you don't typically see a lot of changes in your bicarb levels until a day or so later, unless we make it happen if I'm giving someone bicarb, like if I have them on a bicarb drip or something like that. So this is all oxygenation. So in oxygenation, I'm looking at a problem with flow. I'm going to put you guys on hold for a second. I'm going to see if I can find another picture that may be helpful. So hang on for just 1 second. I'm going to stop sharing and I'll see if I can find a picture. I will be right back. I have it. Okay. All right, let me go ahead and share my screen. This is a different presentation that I did for somewhere else where I worked, but it may help with the oxygenation problem, so you can guys kind of get a visual. So let me share this and see if this helps a little bit. Okay. So if you're thinking, if you're thinking about the alveoli, right, this is your alveoli right here, okay? And this is your capillary blood flow. So you've got your venous blood flow on this side, your arterial blood flow on this side, and this is all at the end of your bronchus, right? So this is my trachea, my bronchial trees coming down, and then I have all these alveoli, all these little seed pods at the bottom. Each little seed pod, each little alveoli has its own network of capillary blood flows to it, okay? So this is kind of getting to the capillary membrane. So all that blood flow, what happens is my oxygen comes down from my heart and it has to exchange, okay? So CO2 is supposed to come out and O2 is supposed to go in. But if this alveoli is collapsed, it can't occur. Or if there's a blockage in blood flow, it can't occur. And so the gas exchange doesn't happen and I end up being hypoxic. So I'm gonna copy this. So in this picture right here, I'll see if I can copy and put it on a paper so I can make it a little bit bigger. All right, so it's going to be a little bit blurry, but okay. So in normal ventilation, so normal breathing, I have a nice big fat alveoli that's open. I breathe in, air goes in, okay? Oxygen and CO2 can make their exchange, and this is my blood flow, okay? Sometimes, though, what happens is I don't have adequate blood flow. See right here, I've got a blood clot right here. Okay. And so I don't have enough blood flow. So I don't have as much room to make that gas exchange. Okay. And so I end up with a ventilation perfusion mismatch. We talked about that a little bit in class. Okay. And then the third thing that can happen is my alveoli collapse. Okay, because I have pneumonia or ARDS. Something has happened to my alveoli. They're full of fluid or something like that. And so what happens is the surface area for the alveoli gets smaller. And so I don't have as much space to make that gas exchange occur. So if you see up here, normally I've got a nice big surface area for that gas exchange to occur. I have a nice big fat open alveoli, and I've got a good blood flow. If I have a PE or I have hypotension, shock, any disruption in blood flow, decreased cardiac output, I don't have as much blood to be able to make that gas exchange happen. So I become hypoxic. If I have pneumonia, ARDS, pulmonary edema, something that is impairing the alveoli and the alveoli start to collapse, I don't have a nice big fat surface area anymore. I just have a very narrow area to make that gas exchange occur. So again, I become hypoxic. All right, was that a little bit helpful? That picture? Okay, so some of it kind of goes back to like anatomy and physiology, like way back when. You probably had that as a freshman. I can certainly post that picture if it's helpful. It might be a bit grainy because it was part of another presentation, but I can post it on the announcements, okay? So I'll do that, and I'll put it in the files. So we'll kind of backtrack here. So again, there's two types of respiratory failure. We're talking about hypoxic respiratory failure right now, okay? So for hypoxic respiratory failure, you're looking at your PaO2 and your O2 sat. What happens is that alveoli is impaired, either with fluid, it's collapsed, it's infected, something has happened to it, and that gas exchange can't occur. So pneumonia is a common cause of hypoxic respiratory failure. So you would think about, if I had a patient with pneumonia, I want to get them to deep breathe and cough. I want to turn them every 2 hours. I want to recruit alveoli, right? I want to get my alveoli back so that they're nice and big and fat so that gas exchange can occur. I want to give them antibiotics. I want to sit them upright. I want to get them mobilized so that they can mobilize that fluid and cough it up and get it out. And I recognize that I'm probably going to hear rhonchi in this patient. So this is kind of how it all kind of ties together. Okay, so if you hear rhonchi with your patient, you know it's probably some mucus. So you need to know that shift, that day you're working, you really need to push in center spirometry, deep breathing and coughing with that patient, because they need to get that stuff out before it becomes a worsening pneumonia. Okay, so that's kind of how you piece it all together. All right, any questions on pneumonia and that type of hypoxic failure? Okay, all right, we're going to move on to the other type of hypoxic failure that you can see. And this is related.
I just
Yeah.
want to make sure that I'm following correctly. So like with the pneumonia, with it being hypoxic, it's going to be a low PaO2, correct?
Correct. Yes.
Thank you.
Yep. So the other type of hypoxic respiratory failure you can see, like we showed on that picture, is my alveoli are open, but I have impaired blood flow to the alveoli itself. Okay, so there's a problem with capillary blood flow of the alveoli. So a common problem that we see with impaired blood flow to the lungs is pulmonary emboli. So if I have a pulmonary emboli, that blood doesn't get all the way to the alveoli because there's some kind of a thrombus blocking it. And so again, that gas exchange can't occur. And so my patient becomes hypoxic. Okay, so pneumonia, PE, these are all ventilation perfusion mismatching. I have a mismatching between the oxygenation that I have available and the ability to exchange it. So that's all that mismatch means. Okay, so in a PE, you have a patient that has sudden chest pain. They are profoundly hypoxic. So on their ABG over here, you're going to see a low PO2, okay, and a low CO2. So their pH is going to be higher. So for this patient, treatment for pulmonary emboli, you can do thrombolytic therapy to break up the clot, anticoagulants to make sure that their blood is thinned out. You can do surgery to remove the clot. So those are types of interventions that they can do to help a patient with a pulmonary emboli. Okay. Let's see what else on here. So again, if you're looking over here at this part, tachypnea, hypoxia, and you look at the patient, right? He looks anxious. So anxiety, tachypnea, dyspnea, tachycardia, those are all signs of hypoxia. So when you see the signs and symptoms of a PE, the signs and symptoms are the same as hypoxia, okay? Because that's really what your patient is. They're hypoxic, okay? So that is kind of talking about oxygenation and hypoxic respiratory failure. Okay, so respiratory failure, we have two types. We have hypoxic and we have hypercapnic. So this is hypoxic respiratory failure. Pneumonia is hypoxic respiratory failure. Okay. So any questions on hypoxic respiratory failure? There's two types. It can be a impaired blood flow, or it can be an impaired alveoli. Okay, so those are the two reasons why I would be hypoxic. Either I'm not getting the oxygen delivered to the alveoli by the bloodstream, or my alveoli are collapsed because of some underlying disease process and that gas exchange can't occur. Does that make a little bit more sense when you kind of split them up? All right, perfect. All right, so I kind of put a little buffer in between the oxygenation and the ventilation here, just looking at some pulmonary procedures. So I did notice there was a question about thoracentesis on the ATI quiz. So that was really good. So thoracentesis, if I have a patient that has pleural effusions and their pleural cavity is starting to fill up with fluid and it's impairing their lungs' ability to expand and stretch, right? Because the pleural cavity is getting too full of fluid, you can do a thoracentesis. So it's a needle aspiration that goes into the pleural cavity and you can pull off that pleural fluid. So if I wanted to go in, so typically for the second space, that would be for a pneumothorax if I have air, because if you think about air rises, right? And so that's why you do the second intercostal space for a pneumothorax. But for a thoracentesis, typically what they're going to do is they're going to do it under fluoroscopy, or they'll go to interventional radiology, or if they've done a chest x-ray and they know where it is, they can do it at the bedside, but they're draining a particular area. So thoracentesis are very specific. Whereas if you're just needling the chest, that's more of a general kind of Band-Aid thing just for a pneumothorax. But yeah, you kind of have the right idea. So for thoracentesis, I'm draining a pocket of fluid. Okay, so for thoracentesis, I want to make sure that the patient has a consent signed. I want to make sure I've got suction in the room, sterile suction in the room. I've got supplemental oxygen with an ambu bag. I've prepped the site with an antiseptic solution. It's usually chlorhexidine. I want to set the bedside monitor to check vital signs every 5 to 15 minutes. So during the procedure, it's every 5 minutes, and then after the procedure, it would be every 15. And then I want to make sure that I've got the appropriate medications for pain and sedation, and the physician will order those. Okay. And then the last thing I want to do is make sure that if they're pulling fluid off and they're sending it down to the lab, that they're labeled correctly. All the specimens are labeled, and you walk it down. Okay. So anything like cerebral spinal fluid, pleural fluid, anything that's like removed from the body, please don't tube it, because if it gets lost, I don't want someone to have to needle my chest again to get a new sample. So typically those types of body fluids, we walk down to the lab just because it was a little more invasive to be able to obtain the fluids. So, okay. So that's kind of what a thoracentesis is. So you want to make sure your patient has good pain medication. They usually do use a little bit of a local at the site, and then they'll give them something maybe for sedation just to keep them calm during the procedure. And then you're there as an assistant to kind of help the physician. So you can prep the site with the chlorhexidine antiseptic solution. If they need suction, you have it right there. If your patient needs oxygen, you have it right there, ready, available, because they got pain medicine and sedation. The consent needs to be signed and witnessed, and then the physician will make a note when they're finished. You always want to make sure as well, whenever you're doing any procedure at the bedside, that you're doing a timeout. So once you have everything, you want to make sure, is this the right patient? Is this the right procedure? Are we doing it on the correct side, right versus left? And do we have the right equipment in the room? So do you have the right resuscitation and monitoring equipment if you would need it? Okay, so those are your rights that you would want to be looking at. Okay. The other test that you do quite a bit is bronchoscopies. So bronchoscopy is where they actually put a tube down into the trachea. So it goes down the throat, down the mouth into the trachea. It has a camera and a fiber optic on the end, so they can see it on the TV screen. So usually endoscopy brings up their endocart, and they have all the equipment on there, and they thread the bronchoscopy tube down. Again, you need the same equipment. Oxygen, vital sign monitoring, suction, all those kinds of things. So it's same kind of prep. You don't obviously need to prep the skin because they're going through the mouth. A lot of times patients gag, so again, they may need a little bit more sedation than with a thoracentesis, just because it's a little bit more invasive than just putting a needle through the skin. But that's kind of a bronchoscopy. So bronchoscopies, they can even do through an endotracheal tube. So if your patient is intubated, they can go through that tube, and they can irrigate the bronchus and suction out patients as well. So if patients have a plug, like a mucus plug, sometimes they'll do a bronchoscopy to get that out. Or if they want to take a specimen, they can also do that, do a bronchial washing and do the bronchoscopy. Okay, so those are the two pulmonary procedures really that are most common that you're going to see. So you just really need to know what your responsibility would be as the bedside nurse. Okay. for those. After a patient has a thoracentesis, you'd want to obviously watch for their breathing is normal, because again, they needled the chest. So you want to make sure that they don't have a pneumothorax. So you'd want to listen for breath sounds, make sure that the patient isn't chronically coughing, watch for bleeding at the site, those kinds of things. And then a bronchoscopy, you would just want to make sure that their gag and swallow comes back before you gave them anything PO. So those are some things to kind of consider for those tests. Okay. So any questions on the pulmonary test or procedures that are there? No? All right. All right. So we're going to go back to our respiratory failure then. So we talked about a hypoxic respiratory failure with like pneumonia, pulmonary edema, a PE, where the alveoli are collapsed or there's impaired blood flow. Okay, so that's a hypoxic respiratory failure. And then the other one is a hypercapnic respiratory failure. So hypercapnic respiratory failure is a failure of ventilation. Okay, so if I go back over to my first page here, okay, and I'm looking at the respiratory failure, I've got hypoxic, which is oxygenation. And I've got hypercapnic, which is ventilation. Ventilation, I'm looking at my CO2 and my pH. So disease processes that are ventilation problems are asthma, COPD, emphysema, right? Those are all ventilation problems, okay? It's restrictive airway disease, right? It's not an oxygenation problem. It's a work of breathing, a ventilation problem. So let's have a look at those, okay? Your tooth fell out? Okay, I'm on video. Okay, get your tooth. My daughter's tooth fell out. She's very happy because she will get some money from the tooth fairy. Okay. So ventilation. I got all distracted. All right, so let's look at our asthma guy. All right, so our asthma, basically what happens is you have a swelling or impairment of those bronchioles. It can be life-threatening depending on how narrow they get. But again, if you imagine the trachea and the bronchial tubes, they start to narrow, right? They swell up and they become narrower and narrower. And so as that air passes through, that's what causes that wheezing sound or that whistling sound, right? So for those kinds of patients, as those airways narrow, the gas can't escape. And so they end up with a high CO2. CO2 or carbon dioxide is an acid. Okay, so that's what CO2 is. It's an acid. And so as it builds up, it makes my pH become more acidotic. Okay, so that's why patients with COPD and ventilation problems become acidotic, because CO2 is an acid. The other problem with CO2, it's a potent vasodilator. So if I have a patient that is acidotic because their CO2 is going up because they're having a COPD exacerbation, I would expect them to be hypotensive, because I know CO2 is a vasodilator, so they're going to vasodilate out. So those are kinds of things that I keep in mind as you're caring for your patient, okay? So again, if you're looking at your asthma patient, look at this: hypoxemia, tachycardia, restlessness, tachypnea. Wow. Okay. So again, you're going to see those come up over and over and over again, because those are signs and symptoms of hypoxia. Okay. So sometimes with asthma, you can see some sternal retractions. They get real short of breath. They have those expiratory wheezes. And again, that CO2 increases. So maybe a question may be, you are working in the emergency department and a 16-year-old comes in with an asthma attack. Okay, what ABG would you expect to see? I would expect to see something with a pH of 7.4 or less, right? Because it wants to be on the acidotic side. So maybe 7.33, 7.32, something like that. I'd expect their CO2 to be high. So I'd expect their CO2 to be maybe 48 or 50 or 55, depending on how badly they look. Okay, I would expect a PO2 to be normal or a little bit low, okay, because they may have a little bit of hypoxia. So maybe it's 80 or 70, something like that. And then their bicarb, if this is an acute onset, their bicarb is going to be normal because their buffer system hasn't had time to activate yet. Okay, so that might be some kind of a question that you may see on an exam or an NCLEX test. Okay, something like that. So that's kind of how it all kind of puts together. Okay, so the treatment for asthma is right here. So you have your albuterol, you have your steroids, you have your Theodor, you have your hydration, oxygen mask, and then your anticholinergics. Okay, so this is kind of the treatment and your presentation for asthma. So again, asthma is an airway disease. So it's a ventilation, a hypercapnic respiratory failure because it's an airway disease, not an alveoli disease, right? Their alveoli are healthy. It's their bronchial tree that is not. So for this patient, I would expect their CO2 to be higher. Because their CO2 is higher, I know it's an acid, so they're going to be on the acidotic side. Okay, their bicarb is going to be normal because typically it's an exacerbation, it's not prolonged, so it hasn't activated yet. And their PO2 may be a little bit on the low side because they may be hypoxic. Okay, because again, those airways are narrowed and those gases can't exchange. The gases can't come in and they can't leave.
You
Okay.
said their pH would be on the acidotic side, right? So it would be like less than 7.35.
So 7.4 is kind of our middle point, right? If it's anything greater than 7.4, we call that alkalotic. Anything less than 7.4, we call that acidotic. 7.35 to 4.5 is kind of our normal. So it depends how they look. So typically they are going to be more on the acidotic side. It could be 7.35, it could be 7.32, could be 7.38. It could be normal, but still on the acidotic side of normal. It depends how high their CO2 is. Okay, but I would expect their CO2 to be high and their pH is going to be low. It's going to be on the lower side. And yeah, you do have to be a little bit careful with albuterol because it will cause tachycardia. All right, is that helpful? Does that make a little bit more sense for asthma being a ventilation, a work of breathing disorder?
This is hypercapnic, right?
Correct. This is hypercapnic.
Okay.
Yeah, hypercapnic. Hypercapnic, all that word means is high CO2. That's all that word means. Okay. All right. So we'll move on to the next couple of disorders that you see. Hypercapnic respiratory failure. Okay. So emphysema, again, high CO2. So if they have a high CO2, they're going to be on the acidotic side. Okay. With emphysema, this is a little bit more chronic. So you may see a shift in your buffer, in your bicarb. Okay, so they may be more on the compensation because sometimes for these are like long term. They live like this for a long period of time. It's not an acute event. Okay. But typically, again, they're going to have difficulty breathing. These are the ones with that barrel chest. They're going to be anxious, dyspneic. Again, these are all signs of hypoxia. They're using their accessory muscles to breathe, right? Their work of breathing gets worse. Okay, so this is a ventilation problem. It is due to restrictive airway disease. Same thing with your COPD down here. Your COPD patient, they typically are sitting upright. This is called that tripod position, where they're sitting up over a bedside table with their arms out kind of like this. Correct. Yeah, emphysema is a type of COPD. So chronic obstructive pulmonary disorder, disease. Okay, so emphysema is a type of COPD. So you see this guy's got an O2 tank. He's on a little bit of oxygen. So a lot of times, even though COPDers are CO2 driven, it is okay for them to receive oxygen. Okay, correct. Their drive to breathe is different. If you are ambulating a patient, or if you have a patient with COPD and their O2 sats start to drop, you do need to put oxygen on. So if you had a patient with COPD and they're hypoxic, maybe their PaO2 is 40 or 50, that's way low, okay? And they won't be able to tolerate that. They would need a couple of liters. You don't want to put a lot of oxygen on, maybe just 1 to 2 liters, okay? But they do need a little bit of oxygen. And a lot of times these patients are on home O2, like 2 liters, 3 liters, something like that, just to kind of keep them stable. So again, this is a ventilation or hypercapnic type of respiratory failure. It's a progressive disease. So again, you would expect higher levels of CO2, normal or low oxygenation. They may need some supplemental oxygen, just a low flow would be okay. And again, for these patients, you want to teach them pursed lip breathing, because you want to teach them controlled breathing, right? So if you think about hypercapnic respiratory failure, it's a ventilation problem. I want to control their work of breathing. So sometimes what I'll do is I would put my hands on their chest and just say, slow your breathing down, breathe in, breathe out. You want to control their rate and their depth of their breathing. Whereas in a oxygenation type of respiratory failure, you want to recruit alveoli. So I'm teaching them deep breathing and coughing and central spirometry. I'm having them, ambulate and move around and cough, and doing a lot of pulmonary toileting is kind of what we call it. With work of breathing, a ventilation hypercapnic respiratory failure, they don't need deep breathing and coughing. They need controlled breathing. I want to control their rate, control their depth with pursed lip breathing, sit them upright in this tripod position. Okay, they still need to be mobile. So these are those patients that I ask them, can you lay down and sleep? If they say no, and this patient's looking like this, and they want to do a CT of the chest laying down, I know they won't do well. They won't tolerate it well. Okay, so I know that I need to go with them to make sure that they're okay, and I may need to do some other interventions. Okay, hopefully it doesn't take too long, and then they can sit right back up again. But a lot of times these patients sleep in a recliner chair, so that's part of that health assessment. I would ask them, where do you sleep? Do you sleep in a chair? Do you sleep in a bed? Are you on oxygen at home? How far can you walk? Those kinds of things. So those are all things that you can kind of ask your patient. So again, if you're kind of looking at this, they could have wheezing, because wheezing, again, is an airway problem, right? Rhonchi and crackles are an oxygenation problem. Wheezing and stridor is a ventilation problem, okay? And this is how you kind of put them in the separate buckets, okay? They can get clubbing of their fingers if it's a progressive, they've had it for a long period of time. They can be very thin because they don't really have a lot of reserve to eat. They can't eat a lot because when they eat, they can't breathe, right? So they become really, really thin. They get frequent respiratory infections, easily fatigued. Okay, so this is kind of your COPD patient. Okay, so that is looking at oxygenation. So we'll kind of go back to the beginning. So respiratory failure, you have hypoxic respiratory failure, which is oxygenation, pulmonary edema, pneumonia. You're going to hear rhonchi and crackles. You're going to do deep breathing, coughing. And then you have a hypercapnic respiratory failure. This is your COPD, your asthma patients. You're going to hear wheezes, stridor, right? It's going to be a little bit different. And then you have your patients that are kind of a mixed bag. ARDS. I'll turn my page. It's our last page. Okay, so now you have your acute respiratory distress syndrome patient. Okay, so these are a little bit more complicated because typically these are a combination. They have hypercapnic failure and they have a hypoxic failure. They are both. Okay, and that's why they're so difficult to treat, and they're so difficult to care for, right? They become very, very sick. Okay, so these are your patients. Like, if you remember that ECMO video that we saw, that was kind of a big hot thing a few years back when I worked in the ICUs with the H1N1 flu, and it was kind of like now. I mean, we were just inundated. We had tents in the parking lots, and just every ventilator was full. Okay, so you see this a lot now with our COVID patients. They end up going into ARDS. Okay, so correct, Heather. Your key is here, ARDS patients, the key is proning and early proning. Okay, because again, if you're thinking about it, even when you're listening to patients' breath sounds, if you listen posterior, you hear better. Why? Why do you hear better breath sounds on the back than you do on the front? You guys know why? So not so much the pressure, but it's kind of your anatomy, right? You have a bigger lung field at the back than you do at the front. So if you think of the front, I've got my ribs right here. I've got my heart right here. Okay. So I don't have as much surface area. Most of my surface area for my lungs is posterior. And so that's why if I lay down flat on my stomach, I get more recruitment of alveoli on my posterior because I have more lung surface area. Okay, so ARDS, typically these patients are severely hypoxic, and this is where you get that refractory hypoxia. So no matter how much oxygen I give you, you don't get better, and you end up getting worse. Okay, so that's what refractory hypoxemia means. So again, they get tachypnic, anxious, tachycardic, right? Signs and symptoms of hypoxia. And they develop shortness of breath, dyspnea. So they develop work of breathing problems as well. Okay. Their ABGs, they end up having abnormal PO2s and abnormal CO2s. Okay. So they end up with high CO2s and low PO2s because it's a combination of both a ventilatory failure, a hypercapnic failure, and an oxygenation or hypoxic failure. So this is a mixed bag. Okay, so these patients typically end up on a ventilator. So complications of treatment is ventilator-associated pneumonia, barotrauma. Okay, so barotrauma again is pressure from the ventilator causes damage to the lungs. Volume trauma is the amount of volume that's being delivered by the ventilator causes damage to the lungs. Okay, but complications are ventilator-associated pneumonia, barotrauma, and volume trauma. Renal failure can also.
Sorry,
Go ahead.
it's just like kind of just a random question, but is that why, especially because this whole coronavirus thing is happening, I've heard that a lot of times, like when someone's on a ventilator, it's like not ever a good outcome. Why is that?
So being on a ventilator depends why you're on a ventilator. With COVID, it's a little bit different because I think it's better now because they do have a little bit more treatment options now. But when it first kind of started, in the springtime, they weren't really sure what was happening. And they were needing very, very high levels of ventilator support to be able to support the patients. And so they needed high volumes, high pressures. And so they had a lot more complications. Putting a patient on a ventilator, if you have a patient that's end stage COPD, they probably will never get off. But if you're on a ventilator because you have pneumonia and then we cure your pneumonia, you'll get off the ventilator. So it just kind of depends on why you're on a ventilator. COVID is a little bit different, and I think they're still kind of finding things out about it. But I do know there was a patient, and I don't know if it was here, but I did see him on TV. They had ended up with a double lung transplant after they had COVID. She was like 32 years old. So I do have like a pathophysiology thing of COVID. I'll look for that and I can put it up next week and we can kind of talk about that in class a little bit more, because usually it's the high dose steroids now that are helping. And again, if you're thinking about pneumonia, ARDS, all those kinds of things, restrictive airway disease, any airway disease, they're typically on steroids to decrease the inflammation. But specifically with COVID, they have found that that is the number one helper in decreasing mortality. And then also using ACE inhibitors. Okay, because your ACE inhibitor converts angiotensin 1 to angiotensin 2 in the lung. And so they found that to be a very helpful treatment option as well. So, yeah. So good questions. All right. So ARDS, there's a whole list of causes of ARDS. So again, ARDS is not a disease process like COPD is. ARDS is a sequelae of events that happen because of something else. So maybe they had a trauma, maybe they have pneumonia, maybe they aspirated, maybe they had heart surgery, maybe they're a burn patient. It could be a multitude, maybe they're a COVID patient, could be a multitude of reasons why they go into acute respiratory distress syndrome. But it is a sequelae of events and it has those 3 stages. But the main thing to remember is it's a combination of both hypoxic failure and hypercapnic failure. And they become very ill. They end up on a ventilator. Proning is the best treatment option. Ventilator support complications are barotrauma, volume trauma, and ventilator-associated pneumonia. You can have associated renal failure as well because they end up in kind of a state of shock with decreased cardiac output to the kidneys, and so they end up in kidney failure as well. Okay, so the reason it's a combination of oxygenation and ventilation is because they become refractory to oxygenation. So their PaO2 is severely low, and it doesn't matter how much oxygen I give them, they don't get better. Okay, and then on top of that as well, they have airway dysfunction. So if you're thinking about the sequelae and the pathophysiology of ARDS, that proliferative phase, I decrease my surfactant production, right? I release inflammatory mediators, which causes inflammation and swelling in the airways. I activate my clotting cascade. So that's what happens in the first phase of ARDS. So the decrease in surfactant level, I get a change in the permeability of the capillary beds, and I start leaking fluid. So I end up in pulmonary edema. I don't have as much surfactant keeping the alveoli open, and so they collapse. Then on the other side, I release all these inflammatory mediators that inflame the tissue lining, the epithelial lining, okay? And so now I release all those mediators and they start creating thrombin and those fibrinogen threads, which create scar tissue. And then on the other side as well, I also activate that clotting cascade and I can start throwing microemboli, which decrease the ability of blood flow to get to the alveoli. So it's kind of a complex sequelae of events. So the best thing is to go back in that PowerPoint and look at the tables and the outline of kind of where it goes. Again, I've got another one that's really good. So I'll make a note tonight and I'll post those tonight on the chat box, those 2 pictures that may help. Looking at ARDS and then looking at the ventilation perfusion mismatching where you have your collapsed alveoli. Okay, so I'll put both of those on there. But that's why it's a combination, because you have multiple things that occur. So yeah, that's a good question, Heather. All right, so that is it. That's all I have for a review for this class. Do you guys have any questions? And then I've got one for 262. So my recommendation for the quiz would be do the ATI quiz, because that will help as well. Just kind of get you in that mode of thinking on that respiratory level, and then go through this study guide. Look at the pictures. A lot of people had said that they're kinesthetic or visual learners, so these pictures hopefully will help a little bit, and start trying to apply some of these concepts to disease processes that you see, and how would you care for those patients? Because that's kind of the questions that you need to kind of be able to answer, scenario type of questions. You have a patient. So like for this, again, I'm just making things up. So if I had a patient, you're the nurse in the medical ICU and you're caring for a patient with ARDS, what ABG would you expect to see? Okay, well, I would expect to see a very low PaO2. I would expect to see an increased CO2, and I'd expect to see an acidotic pH. And bicarb may be normal or it may be compensating. If it's compensating, would it be high or low? Yes, it would be high, right? Yeah. Okay. So kind of have a look at these. We will go over ABGs next week. Okay, so ABGs are not going to be on the test, but it may ask you on an ABG which 2 indicators are for ventilation and which 2 indicators are for oxygenation. Okay, and that's as far as we go for ABGs. We will go through some scenarios next week for ABGs and really talk about them again and start relating your ABGs to patients. What would you expect to see? Why is their CO2 high? Why is their CO2 low? How do you fix those things? Okay, so that's for the next quiz. Okay, it's not for this one. So don't get too stuck on ABGs because we haven't really gone over that yet. Really, it's focusing on oxygenation, ventilation, breath sounds, and respiratory failure. Okay, so just kind of look at the study guide. All right. All right. I'm going to end this conference and I'm going to go over to the manager of care and create a new conference there. And I'm going to do the study guide, review the study guide in that course, because there are a couple of students that are not in 261. So they wouldn't have access to the conferences here. They would only have access to them in that class, in the manager of care class. Okay. So unless there's some other questions, I'll end the recording and hopefully it'll post later tonight. And then we'll quickly go over the quiz for 262. Okay, perfect. All right, so I'm going to pause this.